Hello and good evening, everyone. Good evening, everyone. So, can you please let me know in the chat box if my audio and video is good? So, once you give me a confirmation, I'll start the session. Okay, please let me know if my audio and video is good. Okay, all right. So, we'll start the discussion. So, for the viewers who have just joined, this will be a concise and crisp discussion of the first exam of the NEET PG 2020 series being conducted by DocTutorials. So yesterday we had an exam of 20 questions, 20 MCQs to be answered in 20 minutes. And the exam was live for 24 hours. And now we are having the discussion of that exam. So first of all, let me tell you that this is not going to be a very detailed discussion. I'll try to keep the discussion concise and to the point so that the students who are going to appear in the exam will have full utility of the time. Okay, because now is the time when time is so precious. Okay, right. So let's go forward. At the outset, I just had a go through the results, and I'm happy to see that 4 students have scored full marks. Indrakni Ghosh, Trinath Mishra, Jyoti, and Rohit. So 4 of you have got full marks. Very good, excellent performance. And I can see that others have also done well, scoring, good marks as well. Okay, so all of you keep trying, keep studying well. And so this NEET PG 2020 series will have 20 exams, which includes 19 subject-wise exams and 1 PYQ grant test based on the previous year questions. So we have selected only 20 questions per subject, and all these questions have been framed by faculties themselves, which will give you an authenticity as well to the exams that you are writing. And that is the perfect way to analyze your current performance as well. Okay, so the detailed schedule of the 2020 series is there in all the social media handles of DocTutorials, but I'm just sharing the schedule with you. So today is medicine discussion, and from 7 p.m. today till tomorrow 7 p.m. you will have the surgery exam being live, and tomorrow 8 p.m. Dr. Raja Mahendran sir will be doing a live discussion of surgery 20 MCQs. So make sure that you attend all these exams, and it's a wonderful way to assess your preparation. Okay, right. Right. So we'll have a quick discussion only. Okay, to the point, concise, crisp discussion. Right. Now, before I begin, let me just take a minute to also tell you that the 20 questions that I have put in this paper, they are based on 20 previous year topics of NEET PG. So I've selected each question like that. For example, if you look at the first question, a similar question was asked in the NEET PG 2023, but I did not repeat the exact question. I wanted to see if you were very thorough with the topic per se. So my focus is on the previous year topics. So number 1, the following murmur pattern is seen in. You can see a diagrammatic representation of murmur and 4 options: mitral regurgitation, Kārī-Coombs murmur, patent ductus arteriosus, and aortic stenosis were the options. What do you think, guys? What is the answer? Jasmine, Sai-Chand, what do you think is the answer for this? See, you can see that there is a murmur that is between S1 and S2. So we are thinking of a systolic murmur. Okay. And is it of the same intensity? You know that mitral regurgitation has a systolic murmur. Aortic stenosis also has a systolic murmur. But the answer is not mitral regurgitation. Why? Because mitral regurgitation will have a pan-systolic murmur, and the intensity of the murmur will remain the same from S1 to S2 as the constant pressure gradient is maintained. What is the peculiar shape of this murmur? You can see that this murmur has a typical crescendo-decrescendo shape. Okay, so the shape of this murmur is the typical crescendo-decrescendo. So crescendo-decrescendo shape is associated with mid-systolic murmurs, also known as ejection systolic murmurs. Okay, mid-systolic or ejection systolic murmur. So you can see this, the various systolic murmurs, early, mid, late, and pansystolic. So mid-systolic murmur can be in high cardiac output states, aortic stenosis, pulmonic stenosis, hypertrophic cardiomyopathy, and ASD as well. You will have mid-systolic murmur. But you can see the other option, 𝗂𝗽𝗂𝗯𝘀 murmur here. Now, 𝗂𝗂𝗃𝗃 murmur, remember, falls under the group of mid-diastolic murmur. Okay, mid-diastolic murmur. So 𝗂𝗃𝗃 murmur is seen in association with acute rheumatic fever. It's a diastolic murmur. Obviously, this is not a diastolic murmur. This is a systolic murmur. Patent ductus arteriosus will be a continuous murmur. So the option that is associated with this typical crescendo-decrescendo murmur is the aortic stenosis. Okay, aortic stenosis. Now, let me just give you one additional point. Yeah, Dr. Aisha, good evening. Good evening. Let me just give you one additional point. You can see two murmur patterns here, murmur pattern 1 and murmur pattern 2. There is something common between the two murmur patterns. Both of them are having a crescendo-decrescendo shape. Now, can you tell me which one out of these two is aortic stenosis? And tell me what is the other one. So, crescendo-decrescendo shape, see, the first one is aortic stenosis. Okay, the first one is aortic stenosis. So aortic stenosis is the first one. And you can see that the murmur begins only after a short interval after the S1, which is corresponding to the isovolumetric contraction phase, and then it actually peaks up. But you can see the second type of murmur is one in where the murmur is extending beyond A2. So what do you think is the second type of murmur? Can you tell me, Dr. Aisha, Dr. Sai Chand, Dr. Sahil, what do you think is the second answer? This one is a pulmonic stenosis. Pulmonic stenosis and aortic stenosis, common feature, both are crescendo-decrescendo. Differentiation point, in pulmonic stenosis, the murmur will extend beyond A2. Okay, that is what you have got to know. Okay, right. So the answer is quite clear here. Okay, now going to the next question. Again, toxicology is an important topic, and you may get questions related to paracetamol poisoning, organophosphorus poisoning, zinc phosphide poisoning, snake bite. So here I have asked you a question on organophosphate poisoning. Last year also in NEET PG, there was a question based on organophosphorus poisoning. And here I have slightly, asked a different subtopic in that organophosphorus whole topic. So here you can see the question is, what is a false statement regarding organophosphate-induced delayed polyneuropathy? Okay, so let me just quickly go through it, not a detailed discussion. Let me quickly go through the manifestations. So you know that organophosphate poisoning, there are three phases. One is acute cholinergic phase, second intermediate syndrome, and third is delayed polyneuropathy. The question specifically is on organophosphate-induced delayed polyneuropathy. Because if you see in NEET PG, most of the questions revolve around the acute cholinergic phase, which actually starts within minutes and lasts for 24 to 72 hours. And you have heard about the famous sludge BBB, that is the mnemonic for the clinical features. Patients also will have meiosis, including CNS manifestations. There can be fasciculations and muscle weakness corresponding to the nicotinic involvement as well. Patients in the acute cholinergic phase can go into complications like coma, seizures, respiratory failure, and also cardiac arrhythmias. This is also a potential MCQ based on the clinical features of acute cholinergic phase. Now, intermediate syndrome is also important. This is also a previous year question. Now, intermediate syndrome only happens in 1/5, that is 20% of cases. But please watch out, this develops in 1 to 4 days of exposure, that is 24 to 96 hours. And what is the mechanism? This also can be asked as a question. It is due to recirculation of the lipid-soluble organophosphate compound in the blood, which will result in a receptor dysfunction at the neuromuscular junction. And the patient will get neurological manifestations like neck weakness and various other manifestations. So the last one is delayed polyneuropathy, and please watch out, very important, it develops 2 to 3 weeks after exposure. Okay, and the mechanism is also important. It happens due to the inhibition of NTE. What is NTE? Neuropathy target esterase. So my dear students, if you want the PDF of this session, I'll be happy to share with you. What I'll do is I'll share in my, the WhatsApp groups that I have got, for NEET PG preparation. So I'll be sharing. So don't worry, you can keep writing, but again, I'll be happy to share the PDF with you. This is a symmetrical neuropathy, which preferentially affects the long myelinated axons, resulting in flaccid paralysis of the lower limbs, and patients may develop foot drop or wrist drop. So I'm not saying all patients will develop paralysis, but these are the possible manifestations like flaccid paralysis, which is UMN paralysis or LMN paralysis. What do you think? Jobin, Saurav, Santosh, Jyoti, what do you think? This is LMN paralysis. Patients may develop foot drop or wrist drop. I'm giving you all this information because in another question, they can slightly twist it into a different clinical scenario. So I want my students to be aware on the clinical presentation. Now, coming to the question per se, occurs due to inhibition of neuropathy target esterase is true, but they're asking about false statement. So I do not want to choose this one. It's a true statement. Okay. Then preferentially affects long myelinated axons is true. Causes flaccid paralysis is true. But look at this. Occurs 1 to 4 days after exposure. Now, is this true or false? Now, this 1 to 4 days is not about the delayed polyneuropathy. It is intermediate syndrome. So what is going to be the answer? Answer is option B. Okay, right. Going to the next question. Question number 3. This is again a favorite exam area for NEET PG, malaria. You have to know A to Z of malaria, including the life cycle, the clinical features, the lab diagnosis, and also treatment, including treatment in pregnancy. Everything regarding malaria is important. So I want my students to be very thorough. All are manifestations of severe falciparum malaria. Okay, severe falciparum malaria is the topic. So repeated convulsions, ARDS, hypotension, metabolic alkalosis. What do you think? Very good. I can see Sahil, Jyoti, wonderfully answered. See, you must know what are the manifestations of a severe falciparum malaria. It's a very important topic. So let me just quickly go through it. Impaired consciousness, repeated convulsions, renal failure where the creatinine goes above 3 mg/%. But what is it? It is metabolic acidosis and not metabolic alkalosis. Okay, the common acid-base abnormality associated with malaria is metabolic acidosis, jaundice, severe anemia, pulmonary edema, hypoglycemia, hypotension, very important, abnormal bleeding and DIC, hemoglobinuria, and hyperparasitemia. These are the manifestations. Okay, so all are features except what? Metabolic alkalosis. Going to the fourth question. Again, an interesting question which will require application of knowledge. 64-year-old woman is admitted to the hospital with sudden onset headache, and they've already given the diagnosis as subarachnoid hemorrhage. Angiography shows a PCOM aneurysm, and obviously this has to be treated, but with either coiling or what is the other method? Can you tell me? Here the patient was treated with coiling. What is the other method of treating an aneurysm? Let me know. It is clipping, right? Coiling and clipping. So here coiling was done, and you can see that the patient developed some new deficit. And what is that deficit? It is a left-sided weakness. Okay, 6 days later. So only after a gap of 6 days, the patient developed a neurological deficit, and head CT showed an infarct in the right cerebral hemisphere corresponding to the weakness of the left side. He had a problem in the right side of the brain. Laboratory studies do not suggest infection or metabolic dysfunction. Which of the following is the most likely cause of her new symptoms? So NEET PG 2023 had a question based on a clinical presentation of subarachnoid hemorrhage, and they asked about what is the next step. You might have gone through my recall video, which is available in YouTube as well. But here I've asked slightly different question based on the complications. Now, if you see the 4 options, can you tell me what is a common feature of all the 4 options? Ahana Chaddopadhyay, Pratyusha, can you tell me what is a common feature? All these 4 features are complications of subarachnoid hemorrhage. Okay. Now I have to find out which complication has happened. If you look at the options, see, they have given that the CT is showing an infarct. So imaging, they have not given any evidence of hydrocephalus. Can hydrocephalus cause a neurological deterioration? Yes, it can. But again, in the imaging, nothing it has been mentioned regarding any sort of hydrocephalus. So I can actually eliminate, because otherwise the imaging result, they would have showed that there is hydrocephalus. And also they have clearly mentioned there is an infarct as well. So I'm not going to bring in hydrocephalus here. Could it be rebleeding? Rebleeding is a complication, but if there was a rebleeding, it would have been picked up in the CT scan, correct? CT is very good investigation for picking up bleeding. So it is not going to be the answer. Because what is rebleeding? Aneurysm again rupturing, causing bleeding. So that is also not the answer. SIADH. SIADH can result in hyponatremia, and that can result in altered sensory. You know, there can be two reasons for hyponatremia in a patient with SAH. One is syndrome of inappropriate ADH secretion, and the second one is syndrome known as CSW. And what is CSW? CSW stands for cerebral salt wasting. Okay, cerebral salt wasting. Okay, so both can cause hyponatremia, but here they have clearly given there is no evidence of any metabolic dysfunction. So no metabolic dysfunction means all the lab parameters are normal. Okay, so I am not going to consider SIADH as well. Again, I am going to consider what has resulted in an infarct. So DCI, you know, DCI or delayed cerebral ischemia is the possibility here. Because as a result of the excessive vasospasm following a subarachnoid hemorrhage, it can result in a delayed cerebral ischemia and infarct. And this is very common, you know, when we have patients admitted with subarachnoid hemorrhage in our wards. We would be closely monitoring this patient for any further neurological deficit that develops due to an event like delayed cerebral ischemia. So this delayed cerebral ischemia has resulted in an infarct in this condition, resulting in the new onset of left-sided weakness. So that is clear. Question number 5. All the following are warning signs of dengue viral illness except. So 2023 NEET PG had a question based on a clinical scenario of a patient based out of Delhi presenting with fever and some manifestations of thrombocytopenia. Again, what I have done in this paper is I've taken the topic, but I have put a different question. My dear students, this is how questions are often framed. The topics, the most important topics remain the same, but the questions which are asked from these topics might slightly change. So that's why in these last few weeks leading on to NEET PG, I want you to emphasize mainly on the previous year topics. Now they have asked a question based on warning signs, and I can see Jyoti, Mukesh, Saurav. See, good, very good. See, for the management of patients with dengue fever, you are actually grouping them into Group A, Group B, and Group C. So I have explained this in my lectures as well. Group A, you will go for OP management. Group B, IP management, and Group C would require emergency management. So Group A means dengue viral illness without warning signs. Group B means dengue viral illness with warning signs, and Group C is a severe dengue viral illness. So I am here to assess your knowledge about the warning signs. So what are the warning signs? Abdominal pain and tenderness is a warning sign. Persistent vomiting is a warning sign. Signs of fluid accumulation, which may be a pleural effusion or ascites. Mucosal bleed is a warning sign. Hepatomegaly more than 2 centimeters is a warning sign. And a rapid increase in hematocrit with a fall in platelet count is also a warning sign. These are the warning signs. So you can see I've eliminated option A, option C, option D. Retroorbital pain is a classic feature of dengue fever. So just because a patient has a retroorbital pain, it is not going to give me any warning sign. It is a feature of dengue fever per se and not a warning sign. So that is going to be my answer here, option B. Okay, right. Let's go to question number 6. In the management of tuberculosis, there is subdivision into intensive phase and continuation phase in. So tuberculosis, as always, very important. You can expect a lot of questions. And if you ask me something regarding treatment, I would say that treatment regimens are important. And secondly, the pharmacology of anti-tubercular drugs, they are also important. You know, you can expect questions based on these two from the treatment perspective. Here, I'm trying to assess your knowledge on the treatment regimens. Now, you know that in the management of tuberculosis, This is the algorithm which I have explained in my lectures, which I'm just not going to it right now on how to evaluate. But again, I'm just telling you about the various regimens. You have got a drug sensitivity TB regimen, the H monopoly DR TB regimen, then shorter MDR RR regimen, and longer MDR XDR regimen. These are the common regimens that you should be knowing about, right? So remember, in case of drug sensitivity regimen, definitely there is a division into intensive phase and continuation phase. HRZE for 2 months and HRE for 4 months. Okay, no doubt about it. And for both new and previously treated TB patients, it remains the same. And you can extend the continuation phase by 12 to 24 weeks in certain special scenarios like disseminated tuberculosis, central nervous system tuberculosis, and skeletal tuberculosis, right? Okay. Now look at this. One option was H monopoly DR TB regimen. Now in this regimen, you are giving 6 to 9 months of treatment with levofloxacin, rifampicin, pyrazinamide, and ethambutol. But look at this. In such a regimen, there is no division into intensive phase and continuation phase. Did you understand? Now, what about the shorter and the longer regimens? Now, you know that in the theory part, I have told you in which scenario to consider the shorter and which scenario to consider the longer one. So I'm not going into it to the details right now. But as far as the regimen is concerned, the shorter MDR TB RR TB regimen, that is a rifampicin resistant TB regimen, will have an intensive phase of 4 to 6 months and a continuation phase of 5 months. And the total treatment regimen will be around 9 to 11 months. Okay, right. So the longer MDR TB, XDR TB regimen is based on the grouping of drugs into A and B. I have explained in my lectures what is group A, group B, group C, not going into it. But what I want to stress here is that here you can use a fluoroquinolone, then a bedaquiline, linezolid, clofazimine, and cycloserine with a duration of 18 to 20 months without a division into intensive phase and continuation phase. So this longer MDR TB regimen, as well as your H monopoly regimen, there is no division into intensive phase and continuation phase. And the question here is asking about which one has a subdivision into. So this is out, this is out. What is going to be the answer? The shorter MDR TB rifampicin resistant regimen is having a subdivision into intensive phase and continuation phase. Okay, so I hope that is also clear. Let me go to question number 7. Again, HIV. Again, let me tell you, last year in NEET PG also, there were questions from HIV. And I think this is one topic from which you can expect more than one question, because medicine, pharmacology, microbiology, so pathology, lot of areas are there from which you may get questions as far as HIV is concerned. So this question is again a proper medicine question. It is based on the guidelines. Now, at least some of you will be wondering, sir, should we know all these guidelines? Remember, for HIV, the NACO guidelines are very important, and you can definitely get questions from it. I have simplified the guidelines in my lectures. I hope you have gone through it. So what is correct regarding the management? So basically, can you tell me what is the ultimate motto of me putting this question? It is just to test your knowledge of something known as IRIS, which is immune reconstitution inflammation syndrome. Okay, IRIS. You must know about IRIS. Now, if you look at this, in HIV TB co-infected patients, the screenshot that I have shared with you right now on your screen is from the guidelines, from the NACO guidelines. So you can see that in case of HIV TB co-infection, you have to start the treatment as soon as possible within 2 weeks of initiating treatment. This is for HIV TB co-infection. Okay, within 2 weeks you have to start. So why are you starting it within 2 weeks? Because if you start concurrently, there is a possibility of IRIS. So the question here is specifically asking about TB meningitis. So in case of TB meningitis, there is a slight difference. In PLHIV, that is person living with HIV with TB meningitis, ART should be delayed for at least 4 weeks. Okay, and initiated within 8 weeks after TB meningitis. So it is between 4 to 8 weeks that you should actually initiate. So here the answer is option A, that is ART to be delayed for at least 4 weeks after the treatment of TB meningitis is, initiated. Otherwise, there is a possibility of iris. Okay, so I hope that is very clear to you. Any doubts in that? Okay, very good, 𝗵𝗻, you're absolutely right. Okay, I'm glad that you all picked up regarding the TB meningitis part in the question. If it was TB, then again, you would have to go for the 4 weeks. But here, question is specifically about tuberculous meningitis. Okay, good. Question number 8, again, a favorite question area, both for NEET PG and INICT. Favorite topic area. And we have seen questions being asked in different shapes. Okay, so a 10-year-old boy presented with a swelling of the jaw. Bone marrow aspiration is shown. On further evaluation, the patient is detected to have translocation 814. And you can see the bone marrow aspirate as well. So the options are Burkitt's lymphoma, myelodysplastic syndrome, acute myelogenous leukemia, and hairy cell leukemia. But I want to know from you in the comment section, Dr. Devashu, Sahil, 𝗵𝗻cie Chithan Reddy, I want to know from you what exactly is this bone marrow finding that you are looking at. So what is that finding which is quite striking for you? I can see most of you answered. So can you tell me, what is that finding? So you are seeing lot of cytoplasmic vacuoles. Can you see all these vacuoles? So you're seeing all these cytoplasmic vacuoles, which is again, in this clinical context and the translocation 814, you're thinking of a Burkitt's lymphoma. 𝗵𝗻, it's not just a starry sky that we are looking at. You can see the vacuoles. Obviously, starry sky appearance is there, but that is because of the proliferation rate. But what you're looking now is the cytoplasmic vacuoles. So Burkitt's lymphoma is a very aggressive B-cell neoplasm, and it can present in different forms like endemic, sporadic, immunodeficiency associated. So a lot of such sort of clinical presentations are there. Now, in this, the endemic form is the one that would present as a jaw tumor or a facial bone tumor that can spread to the extranodal sites like ovary, testis, kidney, breast. But I want you to stress on this point, the endemic form of Burkitt's lymphoma can present as a mass involving the jaw or the facial bones. The sporadic form will have an abdominal presentation with massive disease, and the immunodeficiency associated form can involve the lymph nodes as well. So I'll just give you one picture. You can see this, swelling involving the face, and this is a presentation of an endemic Burkitt's lymphoma. Now you look at the morphology of the cells. Now that is what is the catch point in the image. You must know that the Burkitt's lymphoma tumor cells are monomorphic, medium-sized cells with round nuclei, multiple nucleoli, and basophilic cytoplasm. And the prominent cytoplasmic lipid vacuoles, please note, are usually evident on the imprints or smears. And the second one, as Dr. 𝗵𝗻cie said, there is an extremely high rate of proliferation and a high rate of apoptotic cell death. That would actually look, when you're looking at the cell population, you would see a very high rate of proliferation. That is what is called as 𝗵𝗃 appearance. Okay. Sorry. Okay, so that is clear. So this Burkitt's lymphoma is strongly associated with translocation among the long arm of chromosome 8, which is the site of 𝗵𝗂𝗯𝘀 oncogene, 8 long arm, and one of the 3 locations of the IgG genes. That is how the translocation happens. 814, 28, or 822. This is also a previous NEET PG question. I want you to focus on that point as well. So what is the common factor? See, since it is involving chromosome 8, in all these 3 scenarios, all cases will show overexpression of the 𝗵𝗂𝗯𝘀 protein because chromosome 8 is involved. Okay, so the answer here is quite straightforward. It is Burkitt's lymphoma. But again, I have highlighted another important previous year topic to you, which is Burkitt's lymphoma. Understood, children? Now, next one, let me see who answers this correctly. The seronegative spondyloarthropathies are associated with which of the following? So, seronegative spondyloarthropathies per se is a very important previous year topics. And most of the time, the question comes from ankylosing spondylitis. But sometimes they do ask questions based on the other type of spondyloarthropathies like reactive arthritis and sometimes even psoriatic arthritis as well. But hot favorite is ankylosing spondylitis, especially regarding the radiology. But here I have again slightly twisted the question. I am going to ask you something regarding the some clinical presentation. Now, there are certain common features to all the seronegative spondyloarthropathies. One of them is the HLA-B27, and HLA-B27 is common. Now, there is something else which is a common feature, that most of the seronegative spondyloarthropathies may, I'm not saying will, may be associated with another finding that is known as enthesitis. So what is enthesitis? Enthesitis means inflammation of the enthesis, which means the tendinous or ligamentous insertions on the bone. Can you see this in the region where the Achilles tendon is getting inserted to the calcaneum? You can see some sort of an inflammation. So this enthesitis can be a common feature of various seronegative spondyloarthropathies. So that is the answer. CREST syndrome is related to systemic sclerosis. Seronegative spondyloarthropathies, it's usually an asymmetric oligoarthritis. It's not a symmetric polyarthritis. It is an asymmetric oligoarthritis. And you can see malar rash is associated with systemic lupus erythematosus. So what is going to be the answer? Option B is the answer. Okay, right. Next, 10th question, most common renal lesion in cryoglobulinic vasculitis. So first of all, let me tell you, every NEET PG exam, there is a high probability area in both medicine and pathology, which is the topic of vasculitis. Okay, you have to be very thorough with this topic of vasculitis, and you can get questions based on that. Okay, so the question is regarding a small vessel vasculitis here. That is an immune complex mediated small vessel vasculitis, cryoglobulinic vasculitis. So the most commonly asked question pertaining to cryoglobulinic vasculitis is which infection is most commonly associated with cryoglobulinic vasculitis. Can you tell me what is the answer? What is the most common infection? As you answer, I will discuss this question. So meanwhile, I'll be waiting for your answers. So renal lesions can be seen in cryoglobulinic vasculitis. In fact, if you look at all the clinical features, the patients can have what are clinical features? There can be a cutaneous vasculitis in cryoglobulinemia. Arthritis can be there. Patients may have peripheral neuropathy. Patients may also have glomerulonephritis. And around 10 to 30% patients can have renal involvement, and it's mainly a glomerular involvement or a glomerulonephritis. And it is membranoproliferative glomerulonephritis, which is MPGN, which accounts for 80% of renal lesions. So the lion's share of the renal lesions in the cryoglobulinic vasculitis is membranoproliferative glomerulonephritis. Answer is option B. And I can see as all of you are answering, very good, very good. Lot of students, Sahil, Krishna, Jyoti, Pujasri, all of you, very good. So it is hepatitis C, which is most commonly associated with a cryoglobulinic vasculitis. Then tell me what is the other vasculitis which is very commonly associated with hepatitis B. Hepatitis B, you will think of which vasculitis? You tell me. Hepatitis B, you will think of, very rarely hepatitis B can be associated with cryoglobulinic vasculitis as well. But when you hear this term hepatitis B, which vasculitis will you think of? Answer, polyarthritis nodosa. PAN, polyarthritis nodosa. Perfect. Okay, right. Next is question number 11. Okay. So choose the correct match about the serology of chronic hepatitis B with high infectivity. So now you have to learn about serology of hepatitis B. On a lighter note, let me tell you, if you have not learned serology of hepatitis B, you are going to attend an exam with 199 questions, because most of the time there will be one question related to hepatitis B and most often the serology. So please focus on it. So pertaining to the serological markers HBsAg, anti-HBsAg, IgG anti-HBc, and HBeAg, what is the correct serology? Now, if you look at this, a comparison between acute hepatitis B with high infectivity and chronic hepatitis B with high infectivity, I'm just comparing it. See, how do I know it is high infectivity or low infectivity? By looking at the viral markers of active replication. So, the markers of active replication, one is HBeAg, which is a qualitative marker of viral replication, which is a qualitative marker of viral replication. And HBV DNA is also a marker of viral replication, which is a quantitative marker of viral replication. Okay, so since the patient, they are asking about high infectivity, I am going to look at the options which only have got high H or a positive HBeAg. So I am eliminating this option. I am eliminating, I'm eliminating that option. Now, the question is about chronic hepatitis B. Now, if a patient has to have a chronic hepatitis B, HBs antigen 𝗵𝗔𝗂𝗃 has to be present. Okay, only then I can call it. So I am not going to take into consideration this option as well, because in both, in the option C as well as option A, 𝗵𝗔𝗂𝗃 is negative. So that cannot be chronic hepatitis B. Now it is between option B and option D. Now, how do I know it is chronic hepatitis B or acute hepatitis B? I will look at anti-HBC. If it is IgM anti-HBC, it is acute hepatitis B. Whereas if it is IgG anti-HBC, it is chronic hepatitis C. So you can see that IgG hepatitis C, you can see in option D, the IgG is positive. Option B, it is negative. So can I just rule it out? So if you look at option D, the patient is having 𝗵𝗔 positive, anti-𝗵𝗔 negative, IgG anti-HBC positive, and HBe antigen positive, which means the answer is option D. All my dear students, if you are clear with this, can you give me a thumbs up in the chat box? If you are clear with this, sir, I am sure of this, I have understood. So in that case, I'll expect a thumbs up from your side. Okay, right. Kabirasan, Mukesh, Purohit, you can answer. Aisha Holder, please answer. Yes? Right, so that is clear. So I want you to go through this table as well. I have discussed in my lectures as well on the serology of hepatitis B. Okay. Question number 12, a 50-year-old man who's a chronic smoker presented with pain in the right arm. There is also evidence of ptosis. Chest X-ray is shown. What is the diagnosis? So carcinoma lung is a high-yielding topic, and you can expect a question based on X-ray, or you can expect a question based on pathology, especially involving the paraneoplastic manifestations. So, and also the genetic mutations associated. So here the patient is a chronic smoker and he is having a pain in the right arm. Now there is also evidence of ptosis and chest X-ray shown. So you can definitely see that there is a homogeneous opacity involving the upper lobe of the right lung, definitely there. Now if you look at the options, see, you can see Pancoast tumor, pulmonary aspergilloma, Klebsiella pneumoniae, SVC obstruction. Now, I know that you would have eliminated pulmonary aspergilloma. Number one, pulmonary aspergilloma will show what is the classical sign that you would see. The air crescent sign is the one that you would see, air crescent sign. So that you have already eliminated. Now, the clinical scenario is not that of SVC obstruction. SVC obstruction, the patient would have some sort of facial congestion, flushing, a raised non-pulsatile JVP. That would be the clinical context of a SVC obstruction. Correct? The patient would be having a swollen and flushing of the face with elevated JVP. So that is not going to be the answer here as well. Okay. Now, at least some students would have confused with Klebsiella pneumonia, because you know that Klebsiella pneumonia is very well known for the famous bulging fissure sign. So at least some of you would have a doubt. Is it bulging fissure sign? Can I think of this as sort of bulging fissure? No. First of all, that is not the position. It's a bit lower down when it has that bulging fissure sign. Most importantly, please look at the clinical scenario. The message I want to give all my students is, see, some questions in your exam, I'm not talking about this. In your exam, NEET PG, they might seem apparently tough and you might stare at the X-ray for long, you're not getting anything. But always remember, please give value to the clinical information that is provided. So the clinical information here is chronic smoker, and he's having some pain in the right arm and also evidence of ptosis. Where have you heard this classically? You have heard this classically in the context of the Pancoast tumor. Okay, Pancoast tumor. So you very well know that Pancoast tumor is a superior sulcus tumor or the apical lung tumor. So when there is a superior sulcus tumor or an apical lung tumor, this can result in local compression of the anatomical structures. So what all anatomical structures may be compressed by an apical lung tumor? Number one, you can have the lower trunk of the brachial plexus being involved. You can also have the sympathetic chain being involved. When the brachial plexus is involved, you can have pain along the inner border of the arm, and also some sort of hand muscle wasting can be there. And sympathetic chain involvement can result in Horner syndrome as well. So the ptosis that you are seeing here in the question as a part of the probable Horner syndrome that can happen in an apical tumor. Okay, superior sulcus tumor. Okay, Horner syndrome. Okay, so the answer here is option A, Pancoast tumor. Question number 13. Pegfilgrastim is used for the treatment of thrombocytopenia following chemotherapy, anemia associated with chemotherapy, mucositis accompanying cytotoxic chemotherapy, or is it febrile neutropenia with sepsis syndrome? Now, this is again a question that is interlinking both medicine and pharmacology, and I think this is again very important. See, this is a slightly tricky question. Okay, I'll tell you the reason why. Now, when you look at 𝗵𝗵𝗃 filgrastim, so what exactly is this? This drug is a pegylated G-CSF, that is the granulocyte colony stimulating factor. And actually, what is the use of this drug? It is FDA approved to prevent the risk of developing febrile neutropenia in patients who are receiving the chemotherapy regimens. There is a chance that the neutrophil count comes down. So basically, it is the aim of this is to prevent febrile neutropenia. Okay, not actually in the management of febrile neutropenia, it's to prevent, where you will give after chemotherapy a single dose of 6 milligram 24 hours after chemotherapy. So basically, it's to prevent febrile neutropenia because it helps by increasing the body's neutrophil levels, by inducing neutrophil proliferation, differentiation, and maturation, and also enhances the survival of mature neutrophils. But look at this question. They are asking about treatment of. Now, if I ask you, per se, can you tell me febrile neutropenia treatment, not to prevent, treatment, is there a role of 𝗵𝗃 filgrastim? The answer is no. The evidence is very less, okay? But only in certain desperate situations where you have a febrile neutropenia along with a sepsis, what can happen is the use of the 𝗵𝗃 filgrastim will help to decrease the duration of the sepsis, and also it will fasten the recovery of neutrophil count. So in that desperate situation, you can use in the treatment of febrile neutropenia with sepsis. Again, the previous year topic that I want to discuss with you is on febrile neutropenia. You can get questions related to febrile neutropenia, but remember, any patient with febrile neutropenia and sepsis, what is the most important management? It is for antibiotics. You have to give broad spectrum antibiotics. Okay, right. Let's go to the next question. Question number 14. Okay. 40-year-old alcoholic presents to the neurology OP with history suggestive of dementia and recent onset seizures. So alcohol, as you all know, is the national drink of our country. And if you have not learned about alcohol-related disorders, I think, a student is not eligible to go and sit in the NEET PG exam. On a lighter note. So this question was slightly tough. Okay. The patient had dementia and seizures. MRI brain is shown. Which of the following is the most likely diagnosis? So even yesterday after the exam, some students, even today morning as well, some students were messaging me, sir, that question, couldn't be 𝗵𝗃 encephalopathy. So can the option be A? Let me just clear it out here. Because they said, sir, 𝗵𝗃 also can present with dementia. 𝗵𝗃 also can have MRI changes. But see, you should read the question carefully here and correlate with the imaging. So patient is having dementia and recent onset seizures. Okay. Now, it is not 𝗵𝗃 encephalopathy. Can 𝗵𝗃 encephalopathy present with seizures, memory loss? It can present. 𝗵𝗃-𝗄𝗃 syndrome can present. But can someone in the comment section tell me why I did not consider the diagnosis of 𝗵𝗃 encephalopathy? The reason is, if it was a 𝗵𝗃 encephalopathy, the pattern of radiological involvement is not like this. It is slightly different. See, I'm just putting some arrows here. Arrow number 1, arrow number 2, arrow number 3. So the first arrow is corresponding to what? First arrow is corresponding to the mammillary body. Okay, mammillary body. The second arrow is corresponding to PAG, which is the periaqueductal gray matter. And the third arrow is corresponding to the region of thalamus. The point here is, if it was the 𝗵𝗃 encephalopathy, yes, you will get some hyperintensities, something bright in the MRI, in the flare sequences. But here, the pattern of involvement is in which anatomical structure? As Dr. Jyoti is telling. Jyoti, well answered. Jyoti, are you the same Jyoti who got the full marks today? If yes, I just wanted to congratulate you as well. Jyoti, please let me know if you're the same person. I saw that student among the 4 toppers, one of them is Jyoti. So I just wanted to know if it was you. So you see here the anatomical structure that is involved in this MRI is the corpus callosum. So it is the corpus callosum that is involved. Okay, corpus callosum that is involved. So this is not common with vernix encephalopathy. So this is common with another condition that is known as 𝗵𝗂𝗯𝗂𝗶𝗯𝗃 disease, which is a type of, again, alcohol-related disorder. So Jyoti is telling, yes, she is the same one. Congratulations, Jyoti. At least 3-4 questions were tricky, and I really appreciate you scoring all the questions correctly. Well answered. So 𝗵𝗂𝗯𝗂𝗃 disease is again an alcohol-related disorder, which is usually seen in the age group of 40 to 60 years, and patients who are severe and chronic alcoholics are the ones who develop this disorder. Now, patients, how do they present? The patients will present in 2 patterns. Either patient will present with acute confusional state with some seizures, or the patient can present with dementia, sometimes a mix of both features. Acute confusional state or dementia, or a mix of both features. Okay, here you can see patient is having both some dementia as well as some seizures and all. So it's combined. But the clinching point is the radiology. The corpus callosum, especially the central part of the corpus callosum, is having a selective involvement in case of this 𝗵𝗂𝗯𝗂𝗃 disease. Okay, now that is the answer here. Obviously, delirium tremens is not having these MRI changes, but another option that is given is multiple sclerosis. Can somebody tell me in the comment section, why not multiple sclerosis? Because multiple sclerosis is also well known to involve the corpus callosum. Can anybody tell me why multiple sclerosis is not the answer? Again, I told you, any question, it's not just the image what is important, the history is also important. Look at this, the patient is presenting with dementia and seizures. This is not at all a common clinical presentation of multiple sclerosis. Multiple sclerosis patients commonly do not present with dementia. Multiple sclerosis patients do not commonly present with seizures. Yes, they can involve the region adjacent to the corpus callosum. You can have Dawson's fingers, but that's not what you are seeing. I know at least some of you would have mistaken this for Dawson's fingers. My dear students, very important, please correlate with history. You know, at least 10 questions in your NEET PG 2024 exam, you can answer based on common sense alone. Even if you are a non-medical person, you look at the question, there will be some or the other point that actually helps. You know, 2 options will be totally contradictory to another. Okay, so suppose if one option is 2 more than 4 and the other option is 4 more than 2, one of the option has to be right, correct? So common sense will actually help you, my dear students. And if you have got a calm, relaxed mind while you appear for such exams, that is going to help you. This is very important. If somebody is asking me, sir, what else should I take or to the exam hall other than my hall ticket, I would say it is that confidence. It is that confidence, the belief in yourself, telling yourself, convincing yourself, I am going to attend this exam with my full potential and confidence. Okay, you stay relaxed, you will be able to think better. A calm mind will think better and answer better. Please remember that. Question number 15, 42-year-old woman who has undergone a bariatric surgery and is currently receiving vitamin and mineral supplementation is evaluated for a 6-month history of progressive gait difficulties and leg numbness. You can see it's a long question, right? I know at least some of you would have been scared by the sight of the question. Okay, but I'll tell you how I would actually solve this. Neurological examination shows a spastic ataxic gait. Matlab, there is a combination of UMN, that is a spastic plus ataxic gait. Okay, Romberg sign, UMN distribution of weakness in the limbs with bilateral 𝗵𝗂𝗯𝘀𝗃 sign, impaired vibration sense and joint position sense in the toes. So, you know, if you just go through this part of the question, let me see who answers this in the comment section. Can you tell me which anatomical structures are involved? I'm just telling you the proper thought process. Which anatomical structures? So you can see there is bilateral 𝗵𝗂𝗯𝘃 sign. Okay, there is some sort of gait problem. There is some sort of spasticity, UMN weakness. So definitely there is some sort of a corticospinal tract being involved. Yes or no? There is a corticospinal tract being involved. Plus, there is impaired vibration leg numbness, which means there is a definite involvement of posterior column as well. Now, what disease do you know in the spinal cord which affects the corticospinal tract and the posterior column? What is a disease that you know of? you know about subacute combined degeneration of the spinal cord, which is most commonly associated with vitamin B12 deficiency. So this is usually a clinical presentation of subacute combined degeneration of the spinal cord. But the clinical context is not that of subacute combined degeneration, because that is very commonly asked in your exam. They commonly give a history of a patient who is a pure vegetarian, but they have given nothing regarding that. They have given a history of some bariatric surgery, and he's already receiving some vitamin and mineral supplementation. So bariatric surgery is a key point. And another point is the plasma zinc levels are elevated, probably as a result of excessive dietary intake. Supplementation is there because of that. Now, what do you think this is? Now, remember, there are two diseases other than vitamin B12 deficiency which can present with subacute combined degeneration. Let me see who is answering this. What are the two important diseases that can present with subacute combined degeneration other than your vitamin B12 deficiency? Number one, you've got a hypocoupric myelopathy. That is copper deficiency. Hypocoupric myelopathy can present with subacute combined degeneration. Okay, next one is HIV-associated myelopathy. Okay, HIV-associated myelopathy. So somebody is asking, Sahil Shah, how to differentiate from Friedreich's ataxia? See, many points of differentiation. The patient is only having symptoms for past 6 months. You know, Friedreich's ataxia patients, all of them will become symptomatic before 25 years of age. Before 25 years of age, they'll be symptomatic. Correct. So it's a chronic disease process. It's a genetic cause. Like, so it will not have the presentation of 42-year-old. So till 40 years or 41 years, you cannot have a normal patient with Friedreich's ataxia. Okay. Now, hypocoupric myelopathy and HIV myelopathy. So what is the importance of bariatric surgery? When there is a bariatric surgery that can predispose to copper deficiency. When there is a elevated zinc levels, can somebody tell me in the comment section, zinc levels or elevated zinc levels will decrease copper absorption or increase? What will happen? It will decrease. So there are two factors here. Number one, the bariatric surgery, and number two, the elevated zinc. Both of them will decrease the blood levels of copper. And you know that for the formation of ceruloplasmin from apoceruloplasmin, what is important? Copper. You know that ceruloplasmin consists of copper. So for formation of this ceruloplasmin, you need copper. 6 molecules are important. So because of that, you know, what is going to be the answer here? This is likely to be a hypocoupric myelopathy. And, you know, this is likely that the patient will be having a decreased ceruloplasmin. Okay, so did you understand how to analyze this? You can analyze and you can give the answer. So if you can give me a thumbs up if you have understood conceptually on how I have approached this question, please give me a thumbs up. Okay, give me a thumbs up. Okay, right. Okay, perfect. Now the question next is regarding the test for the diagnosis of HIV encephalitis. Again, NEET PG 2023 had a question on HSV encephalitis. So the question was regarding the imaging finding of HSV encephalitis, correct? Now I have asked you a question based on another diagnostic modality in HSV encephalitis, which is the CSF PCR. So for diagnosis of HSV encephalitis, the test of choice would be a CSF PCR. Okay, test of choice would be a CSF PCR viral load, which is the test of choice for the diagnosis of HSV encephalitis. Did you understand? Yes. Are you clear on this? Okay, Chitam Reddy, Sahil Shah, okay, Devanshu Kothari, I hope you are all clear with this. Meanwhile, what was the question asked last time? It was again regarding imaging. There are two important points that you should know regarding imaging in case of HSV encephalitis. Number one is that you can see these two arrows here, right? You can see these two arrows. Corresponding to which lobe? Frontal lobe. Okay, frontal lobe. And you can see these two arrows corresponding to which lobe? Temporal lobe. So the first MCQ point regarding imaging is you should know that the frontal lobe and the temporal lobe are most commonly involved in HSV encephalitis. Point number one. Point number two, this is one encephalitis which can have areas of hemorrhage. So suppose if you are getting a radiology question, okay, remember this is important. It's a previous NEET PG question. Areas of hemorrhage may be seen. I'm not saying will be seen, may be seen in cases of HSV encephalitis. So in clinical neurology as well, when you get patients, when you have a patient presenting with an encephalitic picture, imaging is also showing some findings. If it shows some areas of hemorrhage also, the chance that this is HSV encephalitis is more. Okay, right. Question number 17, what is a typical flow cytometric pattern in case of CLL? So first of all, let me ask you one question, and based on that question, I'll take it forward. So I'll first ask you one question. What is the investigation of choice for CLL? So if there is an MCQ of a clinical scenario of CLL, what is going to be investigation of choice? CLL is very important. CLL is very important. Chronic lymphocytic leukemia is very important topic for NEET PG exams. You may get clinical scenario based questions. You may get questions based on flow cytometry. You may get questions based on what is the criteria for the lymphocyte count. You may sometimes get a question based on treatment. And also sometimes they may ask about what is the name of the staging system. These are the expected questions. So investigation of choice, I can see Jyoti, Pujashri, Mukesh. Yes, you're absolutely right. It is flow cytometry. Okay, it is flow cytometry is the investigation of choice. Now you tell me, the flow cytometry will show the immunophenotyping. So what is the immunophenotype that you expect out of this? What is the answer here? The answer here is what? Can you tell me what is the answer here? CD5, 19, what is the answer here? Okay, what is the answer here? What is the answer here? What is the answer? Option? What is the answer? And also you tell me what is the investigation for CML also. CML, what is the investigation of choice? Okay, so CD5 is positive, CD19 is positive, CD20 is also positive, CD23 is positive. Okay, CD23 is positive. And remember, what about the mantle cell leukemia? You will have mantle cell lymphoma. Mantle cell lymphoma, it is CD23 negative. Mantle cell lymphoma is CD23 negative. So CML investigation of choice is going to be fluorescence in situ hybridization. FISH is the investigation of choice. Okay, right. So here, flow cytometric pattern of CLL is very, very important. Right. Question number 18. 62-year-old male patient developed acute onset of 𝗵𝗂 aphasia and right upper and lower limb weakness, which spontaneously resolved in 6 hours. Blood pressure is 144 on 86. Is a diabetic and on oral hypoglycemic medication. What is the ABCD2 score? So ABCD2 score, what is the importance of the score? So this score is for the prognostication of transient ischemic attack, not for the diagnosis. It is for the prognostication of TIA to assess the stroke risk following a transient ischemic attack. So if you look at this, age more than 60 years. What about the age of this patient? 62. So you'll get a score of 1. The blood pressure, look at this, 144 on 86. So if it is either systolic more than 140 or diastolic more than 90, a score of 1. Patient is having weakness as well as 𝗵𝗂 aphasia. 𝗵𝗂 aphasia is there and weakness is there. You can see for weakness, it is 2 points. For aphasia, it is 1 point. But what if both are together? Should I give 3 points? No. I will only give the highest point, which is 2. That's how it should be done. Duration of the episode, you can see it resolves spontaneously in 6 hours. So again, 2 points. And the patient is diabetic as well. So what is the score here? It is a maximum possible score, which is a score of 7. It's a high-risk patient to develop a stroke. Okay, I hope that is also clear. Okay, ABCD2 score is very, very important. So another important scoring system for your exam is the CHA2 DS2 VAS scoring system. Please also go through it. And also another scoring system which is important for your exam is the 𝗂𝗃65 scoring in case of pneumonia. So 𝗂𝗃65, CHA2 DS2 VAS and ABCD2 score are some important scoring systems that you should know for an exam from medicine. Okay. Question number 19, 57-year-old woman is referred for evaluation of abnormal movements. So what is the current problem of the patient? Some sort of an abnormal movement. Patient had Parkinson's disease 5 years ago and has been maintained on levodopa for the past 4 years. So Parkinson's, so patient is having the symptoms for say for past 4 years. Okay, but now the patient has presented with abnormal movements. Although her Parkinson's disease is under good control. So the features of tremor, rigidity, all those are reasonably under good control. But again, is having some sort of unwanted movements of arms and legs that have been bothersome. What is the medication? So what do you think? Patient with long-term Parkinson's disease on treatment, especially with levodopa, what do you think are these abnormal movements. So, levodopa is basically a dopamine precursor. So when you supplement dopamine, initially the patient would respond well, but after several years, the patient is likely to develop dyskinesia. So levodopa-induced dyskinesia can be there, which will result in certain abnormal coriform movements, which means looking like a chorea. So this can be levodopa-induced dyskinesia. How would you treat a levodopa-induced dyskinesia? Obviously, number one, you will have to reduce the dose of levodopa. And in fact, drugs like entacapone, pramipexole, all are going to, not going to help you, because entacapone is a 𝗵𝗃𝗀-𝗃𝗀transferase inhibitor. You're simply again going to increase the level of dopamine, correct? So there is no point. And even, pramipexole is also increasing. So it's basically dopamine is in excess. So you need not actually give this, these drugs, but you have got to give some drug, amantadine, which is useful in levodopa-induced dyskinesia. So remember, amantadine is having two uses. Number one, amantadine is acting in Parkinson's disease by acting on NMDA receptor. So it's a different mechanism of action. It is acting on the NMDA receptor, amantadine. Okay, NMDA receptor. Okay, different mechanism of action. In addition to its benefit in Parkinson's disease, okay, in addition to the benefit in Parkinson's disease, a second use of amantadine is in the treatment of levodopa-induced dyskinesia. So it is helping in two ways in Parkinson's disease. Now, at least some of you would be wondering, sir, why you are giving amantadine? Why can't you simply lower the dose of levodopa? That's fine. No, you're giving levodopa, patient develop dyskinesia, just reduce the dose. Why can't you, why are you simply giving amantadine? See, the problem is in such patients who are on long-term treatment with levodopa, when you reduce the dose, what will happen is that the symptoms of Parkinson's disease will reappear. So it's a very delicate balance. When you slightly increase the dose dyskinesias will happen. If you decrease the dose too much, then what will happen is patient will have that symptoms of Parkinson's disease. That is why you might have to slightly reduce the dose of levodopa and bring in amantadine as well, which is the drug of choice. Remember, drug of choice for levodopa-induced dyskinesia. Okay, I hope that is clear. Okay, somebody is asking, is it the same as on-off phenomenon? Satish, not exactly the same. On means what? Let me be very straightforward with you. On means it is a period where dopamine is present in adequate concentrations in the blood. Off means dopamine is not present. Okay, so that is, so if there is a scenario where the patient is taking levodopa, but the effect is not coming. The patient is telling, doctor, I'm taking the drug, but I'm not having the effect. Then is when you would say that, there is an off period. Okay, right. Okay. Next is question number 20, the last question. All of the following have been associated with HHV8 except. So again, HHV8, HTLV, all are important. And again, 𝗵𝗃𝗀𝗃 sarcoma per se is also an important previous year topic. So that's why I included this question. All the following have been associated with HHV8 except. Is it primary effusion lymphoma, multicentric Castleman disease, adult T-cell leukemia? See, this condition, that is HHV8 infection, can infect the B lymphocytes, macrophages, endothelial cells, and epithelial cells. So it can result in 𝗵𝗃𝗀𝗃 sarcoma. Then in HIV patients, especially AIDS patients, you can have primary effusion lymphomas, multicentric Castleman disease, which is a lymphoproliferative condition, and a condition known as inflammatory cytokine syndrome. Okay, so these are some manifestations of HHV8. Now, what about adult T-cell leukemia? This is a manifestation of HTLV1. This is a manifestation of HTLV1 infection. Okay, adult T-cell leukemia is HTLV1. So the answer here is at HTLV1. Okay, right. Okay, right. So that's it. Thank you so much, everyone, for joining this session. This is the QR code of my Instagram page. Please, you can follow my Instagram as well for academic updates, and make sure you give every exam of the 2020 exam series. Why I say this is because if you look at this, all the questions have been put by faculties only. So you will have a very, short exam, because it's just hardly 20 minutes. And this is the timetable. So you can see, we have got a lot of sessions coming up: surgery, orthopedics, physiology, pharmacology, in fact, all subjects. This is just a schedule of the first few subjects. The detailed schedule is also there in the DocTutorial social media handles. So I would want every one of my students, you know, to give this. So Mukesh is asking in 19th question, he's having a doubt, why can't it be egg-bomb syndrome? So you're asking about restless leg syndrome. I'll tell you the problem here. Mukesh, see, just think again. See, what is given here? Patient is having Parkinson's disease. So Mukesh Purohit, you tell me, my dear, are we seeing a scenario of, restless leg syndrome? Restless leg syndrome, also patient will have abnormal movements. But you should correlate in this context. In a Parkinson's disease patient developing abnormal movements. You tell me, Dr. Mukesh, is there any direct relationship between restless leg syndrome and Parkinson's disease? Yes or no? No. So yes, as I said, as you said, you can have abnormal movements in various conditions, but you have to apply that in the clinical context given. That is how you would, I'm sure you would have maybe written pramipexole, right? You might have thought it is restless leg syndrome. But what you missed here is the clinical context of a patient on long-term Parkinson's disease now developing certain abnormal movements. That is when you should think of levodopa-induced dyskinesia. Okay, I appreciate your question. It's a valid question, but I hope I have been able to convey that always try to see the question as a whole and not just one or 2 points in it. Okay, I hope you're clear on this. So thank you so much, everyone. Keep writing all the exams of 2020 series, and I wish you good luck for your exams, NEET PG exams, and feel free to connect with me as well. This is my academic WhatsApp number 9447334944. Okay, right. So I'll be happy to share the PDF with you as well of this session. Thank you so much, everyone. Have a good night. Thank you so much.